All right then.
Hello, Nihaal.
Hope
Good to
all
see.
well. Good to
Good
see
to
you.
see you.
Yeah.
Looking forward. Thank you again for your preparation of all these cases and the contributors. Looking
Thanks.
forward.
Thank you for your continued support.
Okay.
All right. I
I'm dis
see.
I'm
Sorry.
disappearing.
Okay. I think Vinith is joined. So first set of cases are from Rainbow. So we'll um okay. I think we're crossed seven. So we'll start off with our cases. The chat is open. So once again, good evening, everyone. And I think it should be a relatively short session. We have only four cases for today. But yeah, your inputs will be welcome. And without further ado, I'll hand it over to Vinith. Over to you, Vinith, if you're there.
Yes, good evening, everyone. Recently, we had a 7-year-old boy who presented to our OPD with complaints of chronically slowly progressive left eye visual difficulty. So initially, he complained of blurring of vision. Then he had difficulty in reaching for objects and overshooting to his left as well, and which progressed to the present state where he could only notice movements which were close to his face. Perception of light was present in both the eyes. So this was his only complaint. Apart from this, normal neurodevelopment, no significant family past or bilateral history as well. On examination, he was found to have macrocephaly, hypocephaly with frontal bossing. There was left visual acuity on the right was 6 by 36 on Snellen's, and the left it was just hand movements at 1 feet. And on fundus examination, he had a pale disc, which was more on the left with suggestive of optic atrophy and partial atrophy in the right eye. And no, motor examination was normal. So complaints we tried to proceed with the neuroimaging. But some bony abnormality, CT was definitely on the table.
All right. As Vinith has pointed out, diffuse calvarial abnormality out here. As you can see, diffuse sclerosis of the calvarium. Also, if you look at the vertebrae, also demonstrate extensive sclerotic changes. But again, the sclerosis and the thickening of the calvarium is more on the frontal bones and along the central skull base. This in turn is causing compressive neuropathy of the optic nerves and over a period of time causing optic nerve atrophy. um, we have an MRI too, so we'll look at the parenchyma and the optic nerves better on the MRI, but on the CT, no acute abnormalities. These are mild prominence of the subarachnoid space along the frontal convexities on both sides, and this disproportionately prominent frontal horns on both sides. Rest of the ventricles did not demonstrate any significant dilatation. No parenchymal changes or on this non-contrast CT. The main finding here is diffuse sclerotic pattern of the calvarium and the visualized bones causing optic canal narrowing and compressive neuropathy. On the MRI, then I think immediately after the CT, nothing in the parenchyma in terms of acute abnormalities. Again, you have this prominence of the subarachnoid spaces, the malprominence of the lateral ventricles out there. In terms of the optic nerves, you can appreciate the optic nerves are reduced in caliber towards the entire length on both sides with these narrowing of the optic canal. So main findings, optic nerve atrophy, some degree of frontal lobe changes, but nothing significant in the parenchyma, and diffuse calvarial thickening out there. With this initial scan, I think the possibilities were thought of diffuse sclerosing disorders that is comes under the spectrum of craniotubular dysplasias. I don't have the images of any skeletal survey if it was done. We only have the calvarial and the upper cervical vertebral images. But these are the main findings. I think we'll come back to this after the scan is completely discussed. But on the imaging findings, these are the spectrum of disorders, and these are the imaging differentials to be thought of after the first scan.
Can I ask?
Yep.
I've seen a patient with craniometaphyseal dysplasia, and in addition to optic nerve compression, he had also hearing impairment secondary to these changes. Is hearing in that patient obviously normal?
Vinith?
His hearing is normal.
Yes, sir. So, yes, sir. Hearing was good.
Thank you.
Yeah, we did have another
No other
case.
kind of.
Yeah, sorry.
Dr. Ramesh, sorry.
No, no, I was saying we did have another child with bilateral facial palsy, hearing impairment, and vision impairment with similar this one a few years back. So
I think
multiple
2020, yeah, we
cranial,
did it, yeah, 2024, I think, if I'm not mistaken.
probably.
It was discussed, yeah, at that time. Yeah, after this, I think child, yeah, Vinith, yeah.
In the background of this clinical history and with such diffuse sclerosis changes in the calvarium, the case was discussed with our neurosurgical team, and a decision was made to proceed with bilateral optic nerve decompression along with optic nerve sheath fenestration as well. And this was done on June 1st. So post-operative, immediately the pupils 3 mm on both sides, reactive to light. Right eye he was fixing and tracking as well. Left eye hand movement same as before. Visual acuity we could not assess properly because of the pain he had and bleeding from the nose as well. But we did monitor him, and 12 hours after surgery, so there was an acute event in the form that the pupils were dilated now, non-reactive, no perception of light in both eyes, unfortunately. And the fundus showed again the same changes, pale dusk, which was more on the left more than right, but without any evidence of CRAU. So with this acute event, which was happening almost 10 to 12 hours after the surgery, our differentials were initially reperfusion injury, probably a hematoma formation as well, or it can be a traumatic injury. And CRAO was ruled out based on the fundus. So we decided to proceed emergency MRI brain with orbits, which was done at around 12 hours after the surgery.
All right. We have the CT, but I think main findings are in the MR brain in contrast. As you can see, post-op changes highlighted here. But I think we'll have to concentrate on the optic nerves. And yeah, in terms of the brain parenchyma, there was no acute abnormalities, no post-operative changes, no collections in the intracranial portion of the brain. Angio was done. I do not find any significant stenosis, maybe some tortuosity out there, but yeah, I don't think it's related to the symptoms. Coming to the optic nerves, close-up images of optic nerves, as you can see on the diffusion wave sequences, the right optic nerve demonstrates restricted diffusion. The left optic nerve also, the intracranial and proximal aspect of the intraorbital portion demonstrates restricted diffusion. The optic nerve atrophy, as seen in the pre-op scan, that is still there, which is also demonstrated on the SAD images. But on the post-contrast sequences, again, you can appreciate that there is bilateral enhancement of the optic nerves. Right optic nerve here, complete enhancement from the intracranial portion to the retrobulbar region. And also the left optic nerve, we can see here from the going up to the chiasmatic, prechiasmatic region, going up to the retrobulbar regions. So bilateral changes of diffusion restriction are slightly asymmetrical on the DWA sequences, but almost complete enhancement of the optic nerves on both sides, correlating with the, I think, the clinical presentation of vision loss post-surgery. And one of the possibilities, and what Vinith has already discussed as the imaging finding or the post-operative possibility is, the vision was preserved immediately after surgery. So only after 12 hours, I think the child started having complaints, or at least 10 to 12 hours later. Diffusion changes and edematous changes or intermediate changes can be caused due to cytotoxic edema and breakage of the blood-nerve barrier. And this directly postulates to the theory of possibility of reperfusion ischemic injuries. Then also supporting feature was CRA was ruled out on fundus examination. So yeah, in terms of the post-op imaging, we're thinking in possibilities of transient or reperfusion ischemic injury of the optic nerves on both sides.
Today is post-op day 5. So it's been 5 days since the child had this particular devastating event. So the child was started on pulsatile steroids along with antioxidants. So day 5, still the pupils are dilated, sluggishly reactive right now, and still no perception of light in both the eyes. So our questions were any experience with reperfusion injuries in optic nerve decompression? Any additional differential should be considered? And what is the expected median time if recovery is expected?
I only know from surgery in NF2, where you have involvement of the nerve sheaths, that even if you touch kind of these situations, the ophthalmic artery is extremely sensitive, and this is likely an ischemic event by reaction of the ophthalmic artery. This is, I think, the most likely explanation.
But does it happen during procedure or does it happen delayed,
I
much
don't
later
know, but
after?
I mean,
Okay,
you certainly have a short delay of
correct,
hours. This would
correct.
not be. I mean, I'm not criticizing the intervention and the surgeon at all. Just to make it clear.
No, just we want to understand what could be the explanation of this presentation. That's it.
You know, for example, maybe the comparison is not perfect, but in a drowning injury, sometime after resuscitation, you have a very good recovery. And within 24 hours, the system is breaking down. And I think this is a very vulnerable situation, and a short delay is still compatible with a vascular event, hypoxic event in the broad sense.
So do you mean to say this is reperfusion after a chronically ischemic optic nerve vessels?
I don't know. I don't know.
Okay. Right.
Chronically compressed, then relieved, that is causing hypertension.
Okay. Anybody else has personal experience of this thing?
But have the optic canals been enlarged by this intervention, or have they not been touched?
Yes, but they have been widened. Now the space can be better seen in post-operative CT.
Okay.
That is very sufficiently widened.
Yeah, thanks.
But sir, how will we be able to explain reperfusion in bilateral, like there is in both eyes?
So left side already the vision impairment was quite severe. I think probably light perception on the light side already preoperatively only. Right was better preserved, but it was not completely normal. But both sides there was the compressive neuropathy was there bilateral.
Right.
So left was already quite severe, near blind preoperatively. Right also became no light perception post this one.
Anish, any experience intervention was nothing to be, I think.
No experience personally as such, but yeah, I agree with Dr. Balthazar. It's a post-op occurrence, so has to be a post-op, unlikely to be a medical cause. There is no definite hematoma, cavernous sinus involvement, which I can see on these scans, which are the other things which need to be considered. Yeah, so one could be just handling of the optic nerve, especially the one which was not affected significantly, that can have some delayed neurotemesis, that is why it's a slightly delayed presentation. Or as Dr. Balthazar said, maybe some component of the ophthalmic artery or the artery central retinal artery, which has delayed, gone into vasospasm or occlusion.
Yeah. Dr. Shilpa asked for a fundus examination. Was there hyperemia or new-onset ischemia?
No, sir. No hyperemia on fundus.
It was pale disc, right? Even
yes,
post-operatively.
Yeah.
So, Dr. Nihaal, so the extent of the post-operative changes that we see in the optic nerve, starting from pre-chiasmal segment, even to the post-chiasma also, correct?
Yeah.
Or just stopping short of chiasma. So, does that pattern or that segment involvement, does it tell us anything about the likely pathology? The extent of optic nerve involvement? Difficult to say.
You mean in terms of ischemia or in terms of information is auto different or?
No, I mean, suppose we say in demyelinating disorder, short segment, long segment, like that.
Yeah. In the ischemia, usually it's a long segment thing. As seen in our case, I think one of the prognosticating markers, what they thought was if there is cytotoxic edema involving the optic nerves post-op. I don't have the references, but that is one of, it's a poor prognosticator in terms of the child did not have any cytotoxic edema. There's an infarct or something going on there. Rather than only inflammation and vasogenic edema. That would have been a more favorable prognosis. And already the optic nerves are atrophied, so the functional reserve of the optic nerves before the operation itself is reduced compared to a normal optic nerve. So in terms of the prognosticating markers, some negative findings on the scan, even the chronic optic nerve atrophy and also the diffusion changes. I'm not sure of the experience of when the child regains, if it's a permanent damage or if it's a temporary thing, and how would you medicate the child? So,
Right.
Yeah.
Thank
If it
you.
is an arterial vascular ischemia, I don't think recovery is going to happen. That's pretty permanent.
Yeah.
Okay, Dr. Uddhava, I think has
Thank
mentioned
you.
something in the chat. Maybe you can have a look. Osteopetrosis child had operated and was on pulse steroids. After 1
24
month,
hours post-op, operated fenestration, has similar sudden painless vision loss with non-reactive pupils, treated with pulse steroids, and presumed reason was post-operative vasospastic ischemia with hyperemia, reperfusion. Eventually, after a month on follow-up, she regained vision and was better than the pre-surgical. Okay, so we hope it works. We give steroids and antioxidants, continuing oral steroids. Yeah, we hope so. Thank you.
Okay, thank you.
That's reassuring.
All right, we'll go on to the next case.
Yes, sir. So we had a 6-year-old boy, a Neuro-oncology case, who was admitted twice in the last 1 month. In the first admission, just briefly, the child presented somewhere around May 23rd. He's a known case of B-cell ALL. CLLA was positive. He was brought with the first episode of focal status epilepticus. So this is a focal seizure which lasted for almost half an hour to 45 minutes is what they were telling. The child was intubated as well. So during the first admission, the MRI brain, which was done on day 3 of admission, showed.
Was he on a maintenance dose? Chemo, as far as I remember. Was any
Sorry,
chemotherapy going on?
Maintenance was going on, sir. Induction was done. Only
He
maintenance.
was in remission at this time.
Yeah.
Okay. And presented with focal status. All right.
Yes.
Okay. So day 3 of the symptom onset. On diffusion various sequences, possibly only some punctate either restricted diffusion in the cortical region of the left paramedian and parietal lobe. In terms of diffusion changes, nothing else is demonstrating restricted diffusion. On the flare sequences, there are some additional edematous changes. As you can see, there's the extent of involvement of the cortical region out here is slightly more what you're seeing in the diffusion sequences, and also the inferior temporal lobe, and demonstrates these other cortical subcortical focal abnormalities. One foci is out here, and one over there on the more on the left side. These are the main findings on the scan. And they did not correspond to any changes of hemorrhage or microhemorrhagic foci or blooming. And on post-contrast, there was no enhancement per se. So we thought of differences of post-ictal injury and press-related changes as the child was on chemo and or maintenance dose of chemo and possibly could contribute to these findings. The child was again, evaluated and treated accordingly and had a follow-up scan.
Yes, the child improved quite quickly. By completion of day 2 of admission, the child was already extubated, sensorium had improved, he was following commands as well. And only once in the ICU, we had documented a high BP reading that was just around 95th centile as well. And later CSF analysis, which was done along with culture, PCR, malignant cells, everything was negative. So he was discharged after 6 days with no neurological deficits as well. So last week, he was again brought with complaints of febrile illness. This was non-specific without any localizing signs since 5 days. And fever spikes, they also reduced with antibiotics with just symptomatic management. And day 3, they gave us a review and we did an examination. It was normal. Day 5 of admission, the child was actually planned for discharge. And right in front of the parents, they noticed that there was sudden onset right-sided weakness. The child was playing with the phone, and suddenly they noticed that he was not able to grip onto the phone or lift his right hand. So this was an acute onset and sudden onset disorientation as well, and inconsistent following of commands. So on examination here in this particular event, GCS of 12 with right hemiplegia, upper limb more than lower limb, without any cranial nerve involvement. This was on Wednesday. So just to add to this, further, the child had inconsistent fixing and tracking, which was progressive in nature. So today there is absent menace, absent perception of light with right-sided hemiparesis, with right UMN facial weakness as well. And yesterday morning, he had 2 episodes of clinical seizure for which the child is presently in ICU, well controlled with 2 anti-epileptics, inconsistent falling of commands presently. So during this episode, MRI was done immediately after this.
Okay. Yeah, this is before the ocular abnormalities or symptoms, right?
Yes, correct.
Yeah. Okay. So in comparison to the first MRI, you can see there's progressive changes. The left parietal lobe changes are slightly more focally involved on the lateral aspect. Coming along the medial temporal lobes, you can again appreciate more extensive involvement of the hippocampi, which was not seen on the previous study. And the temporal lobe also demonstrates similar changes, where additional abnormalities in terms of progression, as in the left thalamus. You can appreciate this focal edematous changes of thalamus, and also in the cortical subcortical region of the right half of the cerebellum. On diffusion sequences, the thalamus demonstrated mixed pattern diffusion, some areas of high signal changes on the diffusion sequences. The fornices also demonstrated some degree of mild restricted diffusion. The hippocampi, especially the left hippocampus, on the last image you can appreciate, is demonstrating a few changes of cytotoxic edema out there. So these are the interval changes, some focal periventricular abnormalities that is non-specific in nature, but yeah, these additional changes in the cortical subcortical regions, the cerebellum, and also in the left thalamus are the new changes. Yeah, so this, yeah, to
Could
just to add,
optic
yeah.
nerves, were you able to see anything?
No, optic nerves, there was no nothing, and also on post contrast, there was no enhancement. I don't think I put up the images, but these are the, and no hemorrhages also.
Okay.
So only main findings are these edematous changes, no enhancement, yeah, no contrast, yeah, no other diffusion or any hemorrhagic changes. With that, I think we thought of possibilities of immune or post-infection encephalitis, maybe some degree of contribution from breast and also seizure, given the child had interval seizures. Leukemic CNS involvement we thought was unlikely on imaging because the child did not have any enhancement and any infiltrated type lesions. Any other possibilities thought of anything clinically now?
That's also. As usual, the dilemma was again considering the background of immunosuppression, where it was infection versus immune demyelinating pathology as well.
Yeah.
But the presentation with such acute onset hemiparesis was what was surprising.
Yeah. Okay, if anyone has any inputs, please.
Any slow viral infections that can have this presentation?
Very asymmetrical. Possible,
Okay.
but yeah.
So except the right hippocampus and the
everything is left side.
And very subtle changes in the same areas in the cerebellum. Those they were there in the first scan also, but they were very tiny changes.
So that cerebellum could be press, I think, a part of press on the first scan. It was there.
So it looks like it has evolved slowly.
Yeah.
So we're treating it as demyelinating disorder. We're also covering with antimicrobials, antiviral. Repeat CSF we have sent for more expanded panel, NGS panel, to cover all the viruses, bacteria, even opportunistic infections, fungi. So 3 days.
Was the child on methotrexate?
Methotrexate, okay. No, I'm not sure. Ongoing with this one.
Because we had a case recently in our hospital, methotrexate related neurotoxicity that is usually more symmetrical and white matter, but gray matter can also be involved. Yeah, but we've seen a case with gray.
This one is predominantly gray matter, isn't it? This particular.
Yeah, gray matter and if it was
yeah, but there is, if you see the second image on top, there is some periventricular white matter involvement also. Yeah.
But would you expect them to be showing diffusion changes, given that the toxicity,
acute neurotoxicity can show diffusion changes?
Because these were not there. These were not there on the first
scan. More symmetrical.
Yeah, more symmetrical. But they should have been there on the first scan also, is what I thought.
Yeah.
That is absence of them on the first scan, and yeah. Interval, I think during hospital days, these are the progressive changes which are happening.
Okay. Thank you, Nihaal.
Yeah.
So auto antibodies also we have. Encephalitis, smog, those things are awaited.
And any fundoscopy, anything done?
There are, I think, retinal retinal exudates are there, vitreous exudates, right? Vinit?
These are retinal exudative hemorrhages.
Yeah.
With macular edema. So again,
it can be post-infective or?
Yes, sir. Discuss with ophthalmologist as well. So again, differentials with demyelinating, ischemic, and post-infective as well. So considering the history, more like demyelinating and post-infective.
All right.
Anything is possible, but this child had leukemia and intensive treatment. So I think for me, top on the list is treatment related. You number two.
Okay.
The only thing was again, if the treatment related, that would have been seen on the first scan itself. Because I think the duration of between the two scans is only for 2 days.
1 week only.
1 week. So if it was treatment related neurotoxicity, I would have thought that it would have manifested on the first scan itself. There could be contributory changes, but yeah, these progressive changes most likely.
Sometimes changes lag behind. Sometimes they are before the clinical situation. I think all combinations are possible. I'm not sure, but I think leukemia is here the first diagnosis.
Yeah. Okay. The child had right-sided seizures status or that, and hemiparesis also was there.
Yeah, right hemiparesis, and seizures were focal non-motor seizures.
You had a motor seizure also, no? Today morning.
Yeah.
Right. Today morning, right, sir. Yes, sir.
So thalamic and temporal, medial temporal can be post-hospital signs. But yeah, I think we'll wait for macrobiological evidence if any and antibodies information.
Yeah. Sure.
Okay. All right, to Pune, Sai, if you're there.
Hello, sir, can you hear me?
Yeah, go ahead.
Sir, this is like a previously healthy 7-year-old boy, sir. So normally he was traveling in a bus. So he had, parents complained that he has suddenly loss of weakness with loss of tone, and he had like generalized weakness involving the all 4 limbs. And next he started like drooling from the mouth, and then it's followed by like it like took almost like another 3 hours to reach the nearest hospital. So by the time he entered, he has like this respiratory distress, desaturation, and gasping. So like they require intubation and mechanical ventilation. So and he was shifted to our hospital, and why he came here, the examination was he has like generalized like overall spasticities, hypertonia, and DTRs were like very brisk. So we have done MRI brain. The first MRI brain was done on 7th May. So
the question is sudden episode of generalized weakness. There's no trigger or it's spontaneous or something has triggered.
yes, sir. Yeah, just spontaneous, sir. He's just traveling the bus. That's it. Like
so he's had two episodes. He's had 2 episodes actually, one in December and the other one in May, and both of them actually preceded by generalized loss of tone with copious frothing.
So it's like a seizure?
So we thought it was seizure initially. And then he probably became hypoxic because there was so much secretion in the mouth. And the time to actually reach the first hospital took about 1.5 to 2 hours. And he was in that hypoxic state, and parents, they gave mouth to mouth and they put him on the side and other things. They gave him rescue midazolam because he had a similar episode in December. So December, the MRI was done and all workup was done, and he that was reported as normal, and he recovered. He was completely well in between the 2 episodes. There were no issues. He's otherwise a developmentally normal child. And again, this time also, while he was traveling, he had a similar episode, and there was no preceding illness.
And no respiratory involvement during December, and in May, like there is involvement of this respiratory thing.
We don't have a documentation of the glucose, but I think he was normoglycemic that time. Whatever, they haven't specifically mentioned about the glucose from the December admission.
All right. Okay. Will that we'll go on to the first set of images. No CT abdomen done. No, no needs. I have only 2 MRIs. And these are the first MRI done on 7th May. And as you can appreciate, extensive areas of residual diffusion predominantly involving the cerebral white matter, going from the periventricular region up to the subcortical regions. There is some T2 shine through of the cortex, but the ADC sequence reveal you can appreciate the areas of involvement predominantly of the cerebral white matter. In terms of the deep brain nuclear structures, are relatively spared or less affected in comparison to the white matter changes, and also the posterior fossa structures. So given the degree of hypoxia, I think if it was hypoxic ischemic injury, I think maybe the deep brain nucleus should have been involved, because there is extensive involvement of the white matter and relatively sparing of the deep brain nuclear structures would be slightly atypical for a primary hypoxic ischemic injury is what I thought of. But yeah, predominant white matter involvement. And on the T2 sequences, you have some areas of vascular edema in the posterior putamen and also the posterior thalamic nuclei. The dorsal striatum is slightly more hyperintense than the globus pallidus. And yeah, these T2 hyperintense regions of the cortex, but true diffusion was predominantly seen in the white matter. In terms of the midline structure, there's no herniation at this point of time, and the midline structure are intact. Only a plain scan was done, so no thrombosis, so no vascular abnormalities were appreciated on this present scan.
So the initial scan, the vasogenic edema, could it be explained by, so basically when he presented to us, he was in non-convulsive status.
Yeah.
So could it be...
Yeah, sorry.
Please go ahead. Yeah. Go ahead.
No, I was thinking more of an ALARD type pattern on the imaging.
Yeah, so I think that was the confusion when we saw the scan, because there was no preceding illness, and whether this was alert or whether this is post-hypoxic or post-anoxic changes. So basically he received a low dose of steroids anyways, because we didn't know what we were dealing with. And all his other metabolic screen and everything was negative. Lactates and everything was normal.
No, this does not look like a mitochondrial or metabolic disorder. This looks more like a...
it's predominant cortical. Yeah.
And also, if you look at the hypoxic changes, if you're considering hypoxia, usually the ventral thalamus is more commonly involved than the posterior thalamic nuclei. The posterior thalamic are more commonly seen in postictal related edematous changes. So that is again one more thing, which is again the primary hypoxia. I think there could be a contribution of hypoxia, but the typical the structures which should have been involved are relatively less involved. That is, I think, one point which I thought was against a primary hypoxic ischemic injury. So yeah, this was done, I think, and then we have a follow-up scan. So you want to just brief in between if anything else has developed over time?
Sorry, in this time, there is no recognition of parents or nothing. He's just have some pseudoburbal palsy also now, and he had this dystonia and severe spasticity. So now we have done again the MRI after 3 weeks, to see the changes or anything.
Got it. Oops. Okay, I think I missed out. Okay, I think I missed out on the MRI, the follow-up MRI, but just to point out the main findings, the diffusion changes had significantly resolved, and there was interval atrophy of the brain parenchyma. No interval changes, but apologies, I don't have the follow-up scan, but yeah, diffusion had come down, and there was atrophy of the brain, and no interval changes, if I'm not mistaken. So is that right?
Was there also any atrophy of the basal ganglia structures? Is what
gray matter.
That's okay. It's okay. Yeah.
So we don't have access to the first MRI, is it?
This is the first MRI.
No, with us.
Oh, the December MRI we don't have. No, we don't have.
Okay, now question is, what is he primarily having? Even if we say this is all hypoxic injury, post-aspiration and all, why is he having those sudden episodes of
weakness,
floppiness and then weakness? So could it be some channelopathy like ACNA mutations that can present with
so we did think of this later, because this history came...
sudden encephalopathy.
This history came much later on, probing them again and again. Then the mother, she said, so initially she just spoke about the seizures and the frothing. But we said, we just kept going back to, what happened before. And both the times we thought whether this is some periodic paralysis type of a thing, where he had loss of tone. Because initially also, 24 to 48 hours, he remained limp. And after that, he just came back to his normal status, and he was ambulant and everything. So this is something he went back to his baseline in the first instance.
Okay, so planning to do genetics also?
Yes, sir, we've sent.
Because the primary disease is inexplicable.
Yes, sir.
Episodic presentations.
Just a thought, could it be like a seizure, which sometimes they say, very small percentage of seizures, they have associated cardiac abnormalities, where suddenly the heart stops breathing or there is laryngospasm and then they have a hypoxic event. So they say these are the seizures which are cause SUDEP, sudden unexpected death in epilepsy and all that. Could it be that? Because you said when he came, he had non-convulsive status. So I was wondering whether, and there's hypoxic sort of injury there. So could it be that he could have any of that? There was one article, I think, in the last AOCCNA, somebody had presented on that.
Ma'am, so he was otherwise a well-thriving child, no history of, no significant cardiac history as such. No documented ECGs which showed any arrhythmias or abnormal complexes. And maybe the non-convulsive was post-anoxic. So whatever he has as a primary issue, he must have already had the insult by the time he came to us. And so...
No, that's what I was getting to. So some children or some adults with seizures, at the end of the seizure or during the seizure, they get a very... the heart also, they have arrhythmias and all as part of the seizure only. And then they can go into these hypoxic changes. These are the ones which are dangerous and who are at high risk of SUDEP, sudden unexpected death in epilepsy. So in the AOCCNA, the speaker was showing how the EEG has seizures and then the ECG is showing a continuous asystole at the same time. So I was just wondering whether, and there is no, he didn't say any particular genetic causes of that, but he was just saying be mindful of the children who have seizures, who can have a very severe hypoxia secondary to the cardiac changes, which we don't know why it happens. I mean, I might have that paper. I'll try and share it on the group.
Sure, ma'am. That would be helpful.
If I may, Nihaal.
So Dr. Lokesh asked for toxic screening, Dr. Penna?
Sir, no, we've not done any toxins. So I think urine toxic profile was done, sir. That was negative. Only the urine was done, sir.
Yeah, is the child diabetic, HbA1c?
No, sir, we didn't send. Sir, because only in this current episode, actually, he had hyperglycemia. But the previous ones, so there's no documented hyperglycemia.
Yeah, but since the sugar was raised, at least I think that should have been part of the basic workup, just to see if the child is a subclinical going into a clinical diabetic or not, type 1 diabetes.
Okay, sir.
And the second thing, I think, Nihaal, it's predominantly a white matter involvement.
Yeah.
And if you go to the T2, I think the occipital white matter appears very hypointense. Can this entire thing be an acute hyperglycemic brain injury, which is known in type 1 diabetics, non-ketotic hyperglycemic brain injury? The occipital white matter looks very dark on T2. Next set of images, not diffusion. Yeah, the second image especially. You see the frontal lobe white matter and the occipital white matter periventricular appears very, very strikingly dark.
Maybe. I've not seen a case of such an extensive involvement of hyperglycemia. Maybe.
Yeah, it's more localized in the occipital lobes, such extensive, but just a thought put out there. So I think we need to work up for diabetes also.
Okay, sir. Sir, but subsequently, all sugars were normal without treatment. It was just
Okay.
Only on one occasion it was like.
yes, sir. So, and we don't know whether that was because he was having ongoing seizures or whether that was a stress response.
Okay. Yeah, I think as Dr. Ramesh has raised, the recurrence of the events is slightly concerning because similar episode, similar phenotype on December. Only a single point episode, I think, should have a low threshold. As you have said, are you sent for genetics?
Send, sir. Just we are waiting for the report.
Okay.
So we'll update once we get to genetics.
Raj, you want to say, you raised your hand? Yeah. RCVS, no, not possible, not understanding. Dark white matter, type 2. Need clinical, okay. Yeah, I think that's all we have. That's it, not mitochondrial, not hypoxic, as the brace are spared. Yeah, I kind of agree. Yeah.
I've
Okay,
shared that article on the
yeah.
group I have shared. It's called The Epileptic Heart, the Concept and the Clinical Evidence.
Okay, ma'am. Thank you.
Okay.
Could this be some form of
Thank you.
microvascular injury?
Yeah.
Could this be some form
But those are usually more multifocal kind of. No, this is more extensive. Is what I thought.
Overlap between post-seizure changes as well as microvascular injury, because something very transient and recurring, sickle cell, hereditary spherocytosis, anything like that possible?
So the peripheral smear did not show anything, sir. Plus, he did not have any other involvement. Like he's had 2 events, but every time it was related to the brain. No joint involvement. There's no organomegaly, or actually no. The spleen is not shrunken or anything. He's had ultrasound abdomen in the past. Again, I think there was also one query whether PET or CT was done, but he's not had any labile hypertension or any other autonomic features to suggest that this could be neuroendocrine. If we sort of take that hyperglycemia, I think if it was hypoglycemia, we could have thought about pancreatic and other things, but I don't know.
Okay,
Yes.
okay, Dr. Ben, if you get anything on the genetics or
Sure. I think what was surprising was that the follow-up scan just showed almost complete resolution.
Yeah, that will be more more in favor of an ALRD type of pattern rather than ischemic pattern.
Okay.
They usually have atrophy in 2nd to 3rd week after the clinical onset. So that is again a favorable feature. Hypoxia would have had some degree of gliosis and simulation, at least, given the extensive pattern of involvement over here.
Okay. Thank you. We'll update. Thank you.
Yes, sir.
RCBS will be more focal. This is more extensive, more particle based. We don't have any vascular injury. So yeah, those are the main points. And relatively less commonly seen in children when compared to adults. And more posterior predominant. This is more extensive. All right. I have one follow-up scan with a genetic result for phenotype match. This we had discussed in January of this year. If Apurva is there, I'll hand it over to her to briefly summarize the clinical part. Yeah.
Yes, sir. So this 17-year-old girl, firstborn of a non-consanguineous couple, who was premorbidly well according to parents, she presented to us in January 2026 with a 2-month history of some fever-triggered behavioral issues. She had low mood, withdrawal, and hypersomnolence, and progressing over weeks to gait instability, frequent falls, and eventually inability to walk. And this was followed by marked cognitive decline with mutism poor oral intake, and eventually in encephalopathic state, she presented to us with hypernatremia and transient renal involvement. We did supportive care at that time and saw her MRI brain because of that such history. The MRI at that time we had discussed and worked her up for several causes based on MRI. Her CSF was more or less normal, and electrolytes we had corrected slowly. We worked her up for Wilson disease and could not find anything substantial. As she was encephalopathic at that time, a KF ring by torchlight was ruled out, and we had done deep penicillamine challenge test. Could not find anything significant there, and now as her encephalopathic improved, KF ring was definitely ruled out by slit lamp also. We also worked her up for SSP, CSF, measles, IgG were negative, MOG, NMO, and autoimmune encephalitis. All of those were negative. Then parents took the child home. They did not want to continue medical treatment, and they sought some alternate care. And as the child was not improving, they came to us. Sir, would you like to tell previous MRI?
Yeah, previous MRI, we had seen, we discussed predominantly central areas of edematous changes, as seen over here on the diffuse wave sequences, involving the deep brain nuclear structure, the capsular white matter, and also the brainstem. That is especially the midbrain, with a degree of background of brain atrophy, cerebral and cerebellar atrophy. On the T2 wave sequence, again, we had this partially confluent and multifocal areas of hyperintense changes, some darkening of the globus pallidus and the cerebral peduncles. Some focal abnormalities in the brainstem, more confluently involving the midbrain. Dorsal pons was involved, and overall features of neurodegeneration in the brain. So with this point, this imaging factors and the clinical presentation, as Apurva has pointed out, we had discussed a list of differentials, including SSP, Wilson's, and all that. Everything else was excluded. And on the SW sequences, there was no significant areas of blooming. And yeah, as you can appreciate, the atrophy of the supra and infratemporal brain structures. Yeah, these were differentials, I think, clinical differentials, and what we thought was possibly correlating radiologically and possibly not, but everything was evaluated, and as Apurva has mentioned, everything has come out to be negative. Then the child had a follow-up scan. Anything in between?
Yes,
and what was
so
the
they
interval?
sought some alternative care, but she did not improve gradually. There was chronic progressive disorder. Earlier, when she presented, the course was more subacute. Now it was chronic progressive. There were some movement disorders, including titubation, resting tremor, gait abnormalities, some fascinating gait kind of picture, and she had speech involvement. There was low volume, pressured speech, memory deficits. On examination, rigidity was noted with the prominent tremors. So we did repeat CSF again and could not find anything substantial. KF ring was ruled out, and ANA, everything was normal. So repeat MRI, we went ahead with doing repeat MRI. Sir, this time.
Yeah, repeat MRI, the confluent change, signal abnormalities have reduced. Atrophy also, I think, has reduced in comparison to the first scan. There is some deep brain nuclear atrophy, especially the chordates over here are atrophied with prominence of the frontal horns. There's again darkening, the selective darkening of the globus pallidus, some degree of the cerebral peduncles out there. And also the cerebellar atrophy has a kind of demonstrated interval reduction compared to the first scan. Some patchy residual abnormalities are there, but compared to the first scan, it has significantly reduced. But here, the additional findings on the SW sequences are, you have these areas of now discrete areas of blooming in the globus pallidi and also the cerebral peduncles. This was not seen on the first scan. And spinal cord was screened. I could not appreciate any focal myelopathy or long segment changes. But interval changes, there is interval decrease in reduction in the cortical and cerebellar volume, but there is atrophy of the basal ganglia, especially the caudate nucleus, and these new or more discrete changes of blooming on the SW sequences, especially in the globus pallidus and the cerebral peduncles. On the follow-up chart, this was the main findings, and with that, I think the child was sent for genetics, if I'm not mistaken.
Yes. So we were suspecting some NBIS spectrum in adolescent onset, late onset, after seeing the MRI. But yes.
Yeah, so these two genes had come out. EPRS1 is a mitochondrial, I think, tRNA gene, and SQSTMI1, a gene causing neurodegeneration. Likely pathogenic for EPRS1. Then, if at least radiologically, and look back at these two genes, this is the STMI, and among both the genes, the only one which has documented changes of blooming or areas of iron deposition in the deep central structures is the SQSTMI. In terms of does any of the features match in terms of clinical presentation, Nakula?
No, but these are heterozygous genes
Okay.
or mutations, and these are autosomal recessive diseases.
Okay.
So this is just a carrier. She's a carrier.
Okay. All right. So imaging wise, yeah, this was one of the on the SQSTMI. These were the main findings: some degree of atrophy and some degree of iron deposition. But only few of them, only 2 out of the majority of the cases demonstrated this iron deposition. And in terms of EPRS1, again, it is a hypomyelinating disorder. Our child does not behave like a hypomyelinating kind of a disorder. So at least imaging, I thought, was not a match for the EPRS1 gene too. Yeah, if any.
Yes, so we are also not very sure. The genetics hasn't helped us much. So if there is any, yeah.
So how do they label this likely pathogenic? Just a question from a radiologist.
The variant is likely pathogenic, but in the child's context, because it is heterozygous autosomal recessive, this is not the disease causing, or maybe if there is some compound heterozygous state, some gene which is not identified, we can consider. But according to you, the EPRS1 is not at all matched.
No, it's, I mean, imaging wise, it's not matching.
Yes, sir.
SQSTMI only, few cases I've seen.
Suspecting very strongly, you can do a chromosomal microarray.
Viral rhomboencephalitis, but it's involving the first can had more supratendral involvement. I think all the labs have come out to be negative also.
Yes, sir.
Yeah, Consias would have been picked up. That's not picked up.
There was no history of any seizures ever. We did not do EEG. Sorry, sir. I don't have any videos. If I get, then I'll share with Nihaal sir, and he can share with in the group maybe. I'll try. Yes, sir. It might be helpful. Yes, I'll try to share.
Next step is, what would be the next step? Testing the parents, or that's to be done?
We haven't found any like the gene for the child only. We are not sure of the diagnosis. So at this point, I am not very comfortable with going ahead with parental testing. Maybe some better genetic lab.
Yeah.
Yeah. Yes, sir. Seronegative, whatever. Before sending genetics, we tried to give a child pulse steroids. We explained to the parents that this is just that now we have ruled out most of the possibilities. But given the chronic progressive course, generally autoimmune encephalitis should have a subacute course, but we were not very sure. But we did give the child a course of pulse steroids, and there was no improvement at all with that. We gave her a course of 5 days of pulse steroids and tapering. We then tapered it off in 2 weeks because there was no response at all. The illness was just progressing. Any other, yes, sir, we will, with the help movement disorders, okay, we'll get the phenotype and proceed. But any other possibilities, like when we thought of NBIA after looking at MRI, any other clinical possibility at this point?
I remember one of our patients, of course, the globus parity doesn't exactly look like that, but it was GM1 gangliosidosis, late onset.
Oh, okay, sir. Hmm.
Yeah, that could be a slightly atypical one, but yeah.
Okay, sir. We'll look up and
But
see
the
what.
NVI genes also would have been picked up, I think, if I'm not mistaken.
Yes, sir. We did not find.
And some part has improved compared to the first scan. At least the atrophy has improved. And
So
the
clinically, the
signal
child
chain.
has not, like, has worsened only.
Okay.
So,
SSP completely ruled out?
Oh, no. SSP, maybe all those things.
We sent the CSF to NIMHANS and we got negative panel from there. There's no history of myoclonic jerks also, but
That may happen actually.
sir, sorry, sir.
It may not happen in certain.
Yeah.
It doesn't have to be there.
So should we send the CSF or measles IgG again?
See, the problem is, I think NIMHANS is a very high titers they consider positive. So I don't know whether that's.
Okay, we can try contacting them regarding what exactly were the titers.
There's our lab which is very good. That's at Bombay. I can give you the number if you want.
Yes, sir. Sir, kindly share with Dr. Shikha Jain, ma'am. Thank you.
Okay.
Yes, sir.
Oh, there are some Ayurvedic treatments for SSP which have shown improvement. I've seen the videos, so I'm not sure if no clinical improvement is a sure shot sign for SSP.
You're talking about G therapy, no?
No, there's some center in Pune or nearby somewhere.
Yeah, that's called G therapy.
Okay, gene therapy. Okay.
Named after the founder, Gunwant.
Okay. Yeah, because some patients have shown me that there is significantly, has shown internal improvement. Yeah. So, Pura, I think, as mentioned, further phenotyping and maybe then.
Yes, sir. Thank
you.
Thank you
we
very much
agree
for
that. Yeah, we agree that the genes are not unlikely to be lost.
Yes, sir. Yes, sir. Okay. Thank you very much for that.
Okay. Thanks. Yeah, I think that's our last case, I guess. Yeah, that's the last case. Relatively short session. But we'll meet again in 2 weeks' time. I request all to please send in the cases before the deadlines and all the data to be sent so that it can be compiled accordingly.
Thank you.
Thank you very much. And have a good weekend.
Thank you.
Bye.
Thank you.
Bye again.
Thank you very much indeed.
Take care. Bye-bye.
I'm very impressed how many participants are taking part on a Friday evening. This would not be the case in Switzerland. Definitely not.
Let me see if I can pull up the follow-up scan if people are still there. Dr. Pena, are you there? Is my screen visible by any chance? Oh, sorry. Let's see. Yeah, if my screen is visible, I just pulled up the follow-up scan of the child with recurrent episodes of. So this is a follow-up scan. As you can see, there's some some atrophy, but the changes have resolved. This is the diffusion changes now. They're not there. So there previously. And on the T2s also, yeah. So cerebral atrophy is there, but the white matter changes are almost completely resolved. No residual deep brain nuclear changes too. Yeah. So that would be slightly atypical for only hypoxic ischemic injury. Okay. All right. We'll see you again in 2 weeks. Till then, take care and bye-bye.